I must say that when I received this topic as an assignment, at first I was puzzled and I didn't know where to start from because the point made by this topic seems pretty much self-obvious. Normally one should never even start scanning a patient without knowing medical history. That means without knowing why the scan is performed. And we never start reporting before trying to provide us all the previous images related to that anatomical area. So I decided to use the learning objectives that have been set by the organizers as a guideline for my presentation. And I will go through these learning objectives, discussing 6 cases that are simple cases, but to some extent are paradigmatic of the points we are going to make. So let's start with the first learning objective is to understand the importance of medical history and previous images. And we will start with this first case that is related to an 8-year-old female complaining of neck swelling and pain. And of course, MR is not the first step. She had been submitted to ultrasound, but ultrasound wasn't able to give a full picture of what was going on in the neck. And so the next step was this MR scan. And after 1.5 months, the patient was submitted to a second MR scan because the neck swelling was not improving despite antibiotics. So what can we understand from these images? There is definitely something involving the right thyroid lobe, and there is also some soft tissue thickening and enhancement in the lateral aspect of the neck surrounding the thyroid lobe. And if we wait some weeks and after antibiotics, what we notice is that the right thyroid lobe is now normal, but still there is some thickening that is reaching the skin and is actually opening to the skin, and this is a clinical information rather than MR information. So what we are looking at? Unsurprisingly, the answer to this question comes much more from medical history than from imaging. And why this? Let's start by saying that this is a pediatric patient. So if we have a neck swelling in a pediatric patient, you may very well see that in the vast majority of cases, this is a congenital or inflammatory disease, as opposed to adults when 70% of lateral neck masses are malignant tumors. So this is definitely something different from a tumor. The second point to be made is that we are facing a lateral swelling. So the list of differential narrows to adenopathies, neurogenic tumors, quite infrequent in children, glomic tumors, again quite infrequent, or branchial cleft anomalies. And the third and last point to be made, again, comes from clinical information, because as stated in this case report done by clinicians, third and fourth branchial arch anomalies may lead to acute suppurative thyroiditis. And in all cases of thyroiditis, one should think of a branchial arch anomaly, not the first, not the second, possibly the third or the fourth, which in most cases manifest as fistulas rather than cysts, which are very difficult to pick up on imaging studies, even with the high resolution of CT. But if you have the full picture of medical history, you may understand or at least suggest that this is a fourth branchial arch anomaly, which was then confirmed. So why is medical history necessary? I identified 3 main reasons. The first point is that, as we have seen, clinical data may significantly contribute to build a diagnosis. This is a puzzling case until you know that this is a diabetic patient and that it all started from external otitis. So this is actually Petrus apicitis coming from necrotizing otitis in a diabetic patient and not a tumor. The second point is that head or neck lesions may be manifestation of systemic diseases. And if you have the full picture of the patient, you may understand that very much. This is a pretty aggressive kind of disease of paranasal disease with bone destruction, obliteration of sinus cavities, and the orbital mass. But if you know that this patient has something going on in the lung, you may easily understand or suggest that this is Wegener granulomatosis of the paranasal sinuses. And again, because imaging findings may be misleading, you may very well think that this patient is affected by a supraglottic carcinoma until you know from the medical file that this patient was admitted to first aid 2 days before in another hospital for acute right tonsil abscess. So this is not a tumor, this is inflammation of the abscess of the supraglottis. Case number 2, again, on topic number 1, the importance of medical history and previous images. We are dealing with a patient, a follow-up scan performed 8 years after surgery for adenoid cystic carcinoma. And what the MR scan shows is this large scar tissue in the area of surgical resection. It's a total maxillectomy, and you see the scar going through the masticator space as well. And as we move a bit downwards, we see there is an enlarged lymph node with contrast uptake at the periphery. It's a dark lymph node, but the periphery is brightly enhancing. And if you compare this scan, January 14 with June 13, actually the node is growing. So we are facing an imaging dilemma. Because a node is increased inside, and this patient is a neoplastic patient, so we have to worry about that. And because the signal pattern may be consistent with tumor. But on the other side, we must know that nodal involvement is quite infrequent in adenoid cystic carcinoma. And the signal pattern, though consistent, is not typical. So how can we solve this imaging dilemma? Simply scrolling not only the last follow-up scan, but going back to the first MR scan when the tumor was there, so before surgery, you can see very well that the lymph node was already there. It was smaller, but the signal appearance was quite similar. So this cannot be tumor. This actually turned out to be reactivation of tuberculosis. Case number 3, and we move to topic number 2. To become familiar with typical post-surgical and post-radiation imaging findings. This is a case of a colleague treated for left floor of the mouth squamous cell carcinoma. And as you may see very well, PET scan shows some activation on the right side, so contralateral to where the tumor was. And this is called a recurrent tumor. So the patient comes for MR, and you see very well there is a lot of things going on because surgery has been performed. So you see very well that this area, this hyperintense area, corresponds to a flap that was set to rebuild the floor of the mouth. And you see that where the activation was found on PET, there is this area of intermediate signal, which may be misleading on axial plane, but becomes a bit clearer if you move to the coronal plane, because this is what you were looking at on axial plane. So this is the site of the sublingual gland. And if you move to the sagittal plane, you see that this is actually the same signal intensity you would expect from a sublingual gland, which is probably hypertrophied because it's working also for the contralateral one, which was resected. So what is the point in this case? The point, this is the EPI study. This is a lousy image, but AIST shows also through the ADC map that there is no restriction at this site. So what is the point of this case? The point is that when you are dealing with a patient that has been treated surgically, you must fill in your mind a form with a post-op checklist, which means you must know or you must ask the surgeon what was the access, what procedure was performed, which means what demolition did it entail, and how was reconstructed the anatomy. And of course, there are some variants to the normal that may be due to intraoperative complications. You see very well in this case, there is total ethmoidectomy, and there is medial maxillectomy, but also resection of the anterior cranial fossa floor, which was reconstructed through a flap of connective tissue. Whereas in this case, the reconstruction is a bit different, because in this case, there was intraoperative complication, CSF leak. And so what you see here as a dark area is a bone periosteal flap that has been set to repair intraoperatively the CSF leak. Of course, you understand this image if the surgeon gives you the full information before scanning. And of course, this kind of reasoning applies also for the larynx. When you have a patient treated with an open access for laryngeal carcinoma, you have to count all the normal structures you would expect in a larynx to understand what has gone and what has been left. If you look at this image, no idea, no remnant of the epiglottis. You have the hyoid bone, but no thyroid cartilage. You just have the cricoid cartilage. You have the arytenoid. So what is going on? Simply, this patient has been treated with supraglottic, not supraglottic, supracricoid laryngectomy, and this is the anatomic scheme of what is resected and what is left after this surgery. But if you know what is a supracricoid laryngectomy, to understand those images is much easier. When you deal with a patient that has been treated with laser excision, normally the skeleton of the larynx is not involved. So what you find is a lot of scar tissue due to coagulative necrosis induced by the laser. And so what you see normally in a normal postoperative scan is retraction in the site of the surgery, which is much better displayed by MRI rather than CT. Case number 4, we now move to post-radiation imaging findings with the case of a young guy treated for undifferentiated carcinoma. And this is a follow-up scan. Again, this is the pre-treatment scan, a tumor in the left nasopharyngeal wall. And you see also a nodal involvement. And 23 months after radiation completion, you see 2 masses in the retropharyngeal space, or close to vessels. This small mass over here, and this second mass over there. And they are really very different. You see brightly enhancing with a dark spot inside, mild peripheral enhancement, and a central hypointense area. Are these 2 structures the same thing? The answer comes, as has been told by Professor Karman, by matching the 2 sides, because curiously, this same mass lesion is seen also contralaterally. And if you look at these 2 other patients that have been treated for different patients that have been treated for floor of the mouth cancer and base of the tongue cancer, also with radiation therapy, you see very well that this same small mass lesion is seen also in these cases, and quite frequently bilaterally. This is a finding we are increasingly seeing after radiation therapy, and this is a superior cervical ganglion, which is in most cases enlarged and much more visible after radiation therapy than before, possibly even because of the atrophy of the lymphatics that are normally present in that area. So also for radiation therapy, we need a checklist, and the checklist is made of what is going on of the tumor, but also what happens of the normal surroundings of tissues, mucosa, connective tissue, muscles, lymphatic tissue. And once we know what we must expect after radiation therapy, it becomes far more easy to understand when complications occur. So here on the left side, you see pre-treatment CT scan, a large base of the tongue mass. And here on the left, you see some T2 sections after radiation therapy. And let's move through these sections. You remember where the tumor was. And so where the tumor was, again, you have a hypointense dark area, a retracting area. This is not a space-occupying lesion. This is retracting, so this must be fibrosis, post-RT fibrosis, which is always seen in the part of as a result of healing of the part of the tumor which was growing deep in the tissues. When you have a nasopharyngeal carcinoma, the vegetating part simply disappears after radiation therapy, but what is left of the infiltrating part is some kind of hypointense scar, as in this base of the tongue. Then, normally, you also will see thickening of the platysma and non-homogeneity and reticulation of the subcutaneous fat tissue. You may have variable degrees of atrophy of the submandibular glands and edema in the retropharyngeal space as well as in the supraglottis. This is quite a typical appearance after radiation therapy, and once you know what is the normal picture after RT, you may understand more easily what is not a normal expected image. And you see, in this case, for example, you have a vascular complication, thrombosis of the internal carotid artery, as well as a bone complication, because you have all this area of necrosis. You see lack of contrast enhancement in the core, and bright enhancement, inflammatory enhancement at the periphery. So this is necrosis of the skull base secondary to radiation therapy, or this is a much more known image. This is what happens as a complication of radiation therapy to the brain, and this is brain parenchyma necrosis in the frontal lobe and in the temporal lobe. Quite typical in the temporal lobe for nasopharyngeal carcinoma. This patient was actually treated for adenoid cystic carcinoma of the nasal fossa, so the necrosis is much more obvious at the frontal lobes. And less frequent, but again, fearsome complication, you see this enhancement along the path of the optic nerves, and this is optic neuritis. Now the third point in the learning objectives, to learn about less common anatomical variants without clinical consequence. And I'm happy to see that the variants I'm discussing in the cases are different from those already reported by Dr. Karman, so we are not going to overlap. We will start with a patient with fungal maxillary sinusitis on the left side and an incidental finding, which is represented by this mass lesion in the floor of the mouth. So is this really a mass lesion? Let's move to the axial plane to understand what is going on. And what is going on is that here you have a muscle. This muscle is the mylohyoid muscle, and the muscle shows a gap through which some tissue is growing. And the same appears after the contrast injection on the vibe sequence. This is the muscle, and the gap in between. And curiously, if you look to the contralateral, at the contralateral side, you see that again the mylohyoid muscle shows a gap, and again the same signal intensity tissue is growing through the gap. Let's go back again to the coronal plane, and what you see is that the anomaly is smaller, but present also on the contralateral side. So in a number of patients, you may have, as a variant of the anatomy, some gaps in the mylohyoid muscle, and through these gaps of the mylohyoid muscle, salivary tissue may grow. In this case, both sublingual glands are passing through these gaps of the mylohyoid muscle. When we are talking about the head and neck in general, there is a lot of anatomic variants to take into account. Of course, the paranasal sinus is the place where you will find the largest number of anatomic variants, but you may have variants in the larynx. This is a quite typical condition reported in books and papers. This anomalous deformity normally occurring at the left for some unexplained reasons at the left thyroid cartilage, which at clinical examination may mimic a submucosal mass in the supraglottis. So there is no tumor at this level. It's simply an anatomic variant. You have already heard of, this is actually not strictly speaking an anatomic variant, but is something that may simulate a disease, as well as the retropharyngeal internal carotid artery, and as well as this other anatomic variant, which is reported in all books, but is the hypertrophied pterygoid plexus. If you scan it on the vibe sequence with contrast, this looks like a small mass lesion, but if you look at the same patient on the T2 sequence, you see very well that there is no mass lesion, only some vessels, and this is the hypertrophied venous plexus. But I want to conclude with a more rare, or at least to my knowledge, less known anatomic variant. Through this last case is a patient, again, with nasopharyngeal undifferentiated carcinoma, and this scan is performed in the setting of staging this tumor. And you see the tumor is growing in the nasopharynx, but there seems to be a projection posteriorly in the clavus. You see very well in these magnified images that the same signal intensity seems to grow through the anterior cortex of the clavus, thus invading the clavus itself. Is this really tumor progression within the clavus? Is the cortical bone really breached? The answer comes from the knowledge of this particular anatomic variant that is called the medial basal canal. That is it's very difficult to say, so I must read it. It's the cephaladexic tract of the notochord. What is important to remember is that you may have this subtle canal visible on your images, and it is normally visible distal to the normal synchondrosis. So in the distal part of the clavus, and in some cases it may be puzzling. This patient is not affected by nasopharyngeal carcinoma, but I bet if you find this image, you may be asking what is going on. Is this ulceration? Is something going on? Some inflammation going on, or whatsoever? None of this. This patient has simply an anatomic variant, which means that his medial basal canal is more evident than in the vast majority of patients, of persons. So to conclude, I go back to the learning objectives, and I think that the take-home point is that if you miss some information about medical history, if you miss some previous images, you may be misled in your diagnosis, so you never have to neglect this aspect of your work. And the post-surgical, more than the post-radiation findings, is something that is normally not found in books. For some reason, books never focus on the follow-up of head and neck malignancies. So in the absence of books, what you must definitely do is to stress your surgeon to give you all the information, because once you know what has been done and what has been repaired, it becomes much more easy to understand what is going on and if a relapse is present. And of course, as many anatomical variants you know, the less you will be misled by them. Thank you very much for your attention.